All right. If you do not have your handouts, it was emailed to you. Now, if you need time to retrieve that and you're going to be missing part of this seminar or webinar, then I would recommend that you just pay attention and listen. We are recording this session and we will post this on our website, so you'll be able to at least rehash what topics you may have missed, or you can certainly just review what the courses are trying to imply in here. For those folks that are having difficulties, please give our staff a call by calling again. The number is 1-800-479-6374 and press 0 or 100. This presentation, Don't Leave Money on the Table, makes recommendations and provides insight on ways you can get all or most of the money due to your home health agency. So this could be too late for some of your claims because of the untimely submission. However, the knowledge you receive here will hopefully help you develop practices which will stop leaving money on the table. The information here also applies to your Medicare business and the payers, your other payers such as private insurances. Now, as a supplement to your Medicare revenue, insurance claims or insurance plans are viable and could be a major source of revenue for your home health. So in practical terms, we would not dismiss other insurance payers since we can no longer survive on Medicare alone because of its diminishing reimbursements. Also, this presentation is intended for the benefit of Synergy users. It is an informative segment on how you can recoup overlooked revenue and at the same time act as a training material for using the Synergy software. At the end of this recorded presentation, I'd like to open it up for questions and further talk about the topics that I've presented in here. The sample reports we've used are those of Synergy's Healthcare Assistant. Now, for 20 years, Healthcare Synergy has helped hundreds of home health agencies become successful. We continue with the same mission as we move forward to more changes, including payment reductions in 2013, sanctions, more formidable compliance in the face of accountable care organization, electronic medical records, and pay for performance. Our agenda includes talking about the claim submission timeliness for Medicare. We will also show you how to manage your accounts receivable. Now, this is a very critical component of recouping your payment. So this is very important, and I'll discuss that later on. Now, if it's available or if it's applicable, you can adjust claims so that you can either submit more for revenue's sake, or if you made a mistake, certainly it's also a way that you can return the money that's not due to you. It goes both ways. Also on the agenda, we will talk about how plan changes with your Medicare, if the patient moves from Medicare Original to an HMO or perhaps to a Medicare Advantage, then certainly those are awareness that I'd like to impress upon you today, as well as any MSP complications. Next, I'm going to show you other revenue sources that you can use Synergy to bill, such as outpatient rehab and flu shots billing. Then we are going to discuss the use of software and third-party tools to make your process a lot more efficient. The first item on our agenda is claim submission timeliness. When billing Medicare and other Medicare Advantage insured claims, you need to make sure that you're aware of your expiration dates. There's millions of uncollected revenue just because of mere oversight and lack of sound reconciliation practices. So collect all your monies before it's too late. The timeliness to submit a wrap and a final claim is up to 1 year or 12 months from the last date of service within that episode, not the end of the episode through date. Late filing beyond 1 year is allowed for good cause, but good cause is almost not accepted if it is the fault of the provider. Let's say you were a new agency, but you encountered a hold in your Medicare certification and it went beyond the 1 year period. Now, it is not your fault, but it's mainly an administrative issue from the RHHI or from CMS. Just as long as you get acknowledgement from them that it is their mistake or it's their delay that caused you not to be able to bill timely, then you can simply code your claim appropriately with delay reason codes and remarks. Now here's an example of a timely submission. Let's say you have a Medicare episode from 10/22/2011 to 12/20/2011. The visit dates that comprise that episode are 10/22, 10/27, 10/18, 12/4, and 12/17/2011. The RAP has to be processed, and the final claim has to be submitted on or before 12/17/2012, not 12/20/2012. Okay, so this is an extreme example, but I'm sure you can take a look at a lot of your claims that can be salvaged or submitted prior to becoming untimely. The next tip that I'm going to discuss is how you manage your accounts receivable. Now, there are several series of steps in managing your AR efficiently. If you don't have one, then the best bet is to automate all process if you can. Call your RHHI EDI department and apply for your agency submitter number. For many of you, you have a submitter number and have been submitting claims by batch. So if you need help in getting completing that form, or if you don't know how to contact your EDI department, then give us a call, and our billers or our tech support team would be more than happy to help you. Now, the next step after you've submitted the claim, the tip that I'm trying to show you in here is that you need to confirm that that batch was submitted, and you're going to download and read a report called 277. So every single file that you submit to your RHHI, you will be given a 277 acknowledgement report. So the Synergy software is able to read this for you, but it's very important that you download it and read it each and every submission. Now, some of you are probably not automated at this time, and you are manually keying in claims on DDE. Now, manual method of submitting or checking claims have been proven to be inefficient and prone to using mistakes. Later, I'm going to show you by using third-party providers such as Ability, Ivans, eSolutions, then they will be your solution to be able to upload your claims to the intermediary. Of course, there are individual pros and cons between the value of each one of these companies that I've mentioned, but the decision lies or rests on you. In other words, there are preferences in selecting the third-party vendors for the ease of doing your work or the reports that you can receive from them. You may know that the Ability software has the Ability company has a built-in application for both the file transfer and the DDE access within the Synergy program. This is one of the things that we recommend to most people, especially if they want to streamline the process, because the other third-party tools or software partners that we have are not able to connect automatically to their system. You would literally have to exit out of Synergy, and you would need to go into their specific applications. Now, the next step or the next tip that I'd like to share with you is that you need to post your payments daily. Now, as part of your automation process, instead of manually keying in your payments on the individual ledgers or claims, you might want to make sure that you're using the electronic remittance advice that will be able to be read by the program, and it would literally bring all of that data into the patient's ledger in one sweep. So posting your ERA daily is very crucial in terms of knowing exactly what had happened to each and every claim, whether they got paid, rejected, or if you have a partial payment, or certainly if you have wrap cancellations, thereby being able to resolve them as quickly as possible. The next step after you've posted your payments is that you're going to need to go to the report sections and locate your accounts receivable report. Now the actual accounts receivable sample that I've displayed on the screen right now is called AR Claim Detail. So you would filter it by whatever option you'd like, whether it's the coverage start, the coverage end, or the claim sent date. And basically what you're going to do is unchecked anything that has already been paid, thereby just showing you only the ones that have outstanding balances. So the report on the bottom of the screen is the actual output that you would retrieve after you've invoked this report. And as you can see, there are specific claims with claim periods and amounts that you are going to look for, and perhaps research and figure out why you haven't gotten paid. If they're still in process, that's good, but if they're not in the DDE system, there is something wrong. Probably it got rejected at the batch level, or perhaps there was an incorrect HIC number. There could be a variety of reasons why your claim is not being processed, but for you to be able to identify them using this report is the key in helping you track every single claim. Now, when you are when billers produce this report after payment posting and reconciliation, some people are still noticing that there are balances on their accounts receivable. Well, these are the reasons, and I'm displaying them all for you. There are balances for, and the reasons being are, let's say, number one, payments and adjustment entries should not auto-adjust based on insurance payments. Now, there was a much older version of Synergy that we've accepted what Medicare paid and changed the claim amount to that of Medicare's. Now, we quickly discovered the discrepancy to that model and changed the AR reports accordingly. Payments and adjustment entries should not auto-adjust. That's what we've learned. And so we do not base it based on what the Medicare payment or what the insurance had paid you. So when there's a balance, the biller has to research and figure out what caused that balance to come up. Now, in the library of the chart of account, there is a provision for adjustments and other payment codes. So certainly that's a first step in making sure that your balances are not there unnecessarily or incorrectly. Now, another reason why you have balances in your AR is because there are incorrect calculation in your PPS payments, and the way to resolve that is by going into the claim amount settings. I'm going to show you that on the next screen and how to tackle this particular settings. Now, the next one is maybe you didn't post your payments correctly when there was a partial episode payment, and that's another screen that I'm going to show you in the next 2 or 3 slides, which will show you where we can place that 06 code to conform to the partial episode payment calculation. Also, there could be an ADR, and your Medicare intermediary had denied certain visits. Thus, when the payments are paid, then there's of course a balance. So one of the things that I'd like to recommend to you is do not be quick in charging off the balances. You need to identify if it's something that you can appeal and get payment for them. And certainly you can exhaust all of your appeal rights all the way to the administrative law judge. Now, I'm not going to go through every single one of these. I'm just going to pick and choose. One of the other reasons why you'll have balances is probably because you've met your outlier cap, which is about 10% every year. And we're going to talk about that too as well, knowing whether or not outliers are really something that is worthwhile in retaining revenue. Also, you could have received a 2% penalty withholds because you never submitted your OASIS, or you had a long span of non-submission of OASIS, and then you also perhaps maybe did not participate in the survey program called CAPS. The correct use of as of date in the accounts receivable report is probably another reason for the balance, and I'll show you a screen capture of that later on. And also whether or not you've updated your program, and thus the PPS pricer have not probably been updated, and thus leaving that balance on your report. For the most part, as long as you have internet connection, we will automatically download the correct pricer through the Payco system. However, if you're not, if your computer is not connected to the internet all the time, then certainly what we can do is just manually download the update, and but you would need to call our tech support department for that. Okay. The amount settings, as you know, this type of balance, there is a balance that is shown on this example for about $450.44. And as you can see, the pricer actually tells you what the current and the new claim amount should be. Now, Medicare paid you $3,104.24, but the pricer is saying it's $3,554.68. Chances are you coded your OASIS question that it might be an early or a late episode. So the selection of episode timing could certainly be the reason for the balance on this particular example I'm showing you, but there are two others, such as LUPA add-on payment and partial episode payment. So by toggling back and forth between some of these options, then you can certainly figure out and zero out the balance in your particular claim. The as of date, as I mentioned earlier, this is the accounts receivable aging report. So for those folks that may have needed to know their AR as of a certain end date, for example, as of 12/31 or as of your fiscal year end, then this is a good report to use, and that way you can capture the total amount of AR for your agency, which you can easily give to your accounting or to your cost report preparer. Now, the financial summary screen, as you can see in here, tells you exactly what type of episode that you have. It also gives you the HIPS codes and the start and end date of the period, as well as the utilization of the visits that you've rendered for the patient. As you can see in this example, the full episode payment had been prorated or actually calculated up there, and then you have your outlier portion for a total of an outlier episode. So know the type of episode, and you can also take a look at some of these on the report format rather than on a view. Now, once you've determined that you have adjustments, then here's a way that you can write it off. Now remember, you have to first exhaust the amount settings before you write off. Now if you've figured them out and you can't seem to address or identify the cause of the adjustment or the balance, then what you do is you're going to apply an adjustment in here, and these are some examples of adjustments. You have the overpayments, the underpayments, the contractual allowance, the denials, and the patient copays. And while you're in the ledger, you would simply click on New and select the transaction type, which is the adjustment type. You just have to determine if and when to charge off the claim balances, because as I mentioned to you earlier, if it was an ADR denial, then certainly you may have to leave that balance in there until such time that you have had a resolution on that particular appeal. So know your credits and your debits, and sometimes by looking at your chart of accounts, and if they're not just adding up, maybe you've inadvertently put a credit to a debit or vice versa. Our tech support people would be more than happy to help you if you're quite confused in terms of your adjustment codes. I just want to give a caveat or a warning to folks. Please do not allow everybody to access the chart of accounts, because obviously that is a very important aspect of the software, and if you allow everybody and anybody to get in there, then it could certainly convolute and make a mess of your finances. So in here, I just wanted to show you that these are all the different types on your chart of accounts. I give you a screen capture of the listing of all the different payments, debits, and various credit adjustments. Now let's discuss the number one reason for getting your claims rejected, or especially your RAPs. This is what I've discovered. As a biller, I can see this very predominantly coming up. And all it is that the clinical people or the intake people are not properly coding the section of the program, thereby delivering that code into the UBO4, and the RAP will be coded appropriately and not have to have a delay or rejection. So you're looking at in here under the intake section of the patient's record. You're going to edit that section, and on the admission form you will notice in circle that there's a question, yes or no, whether or not this patient was admitted from another home health. Of course, our first step in producing or in admitting our patient is that, did we check eligibility? So if we've checked eligibility and discovered that there was another agency that you're going to be overlapping with, especially if they have an open plan of care within the period that you're coming in, then this is the section where you would answer yes. Now, before you do all of your RAP billing, you want to make sure that you contact that other agency and inform them that there is a transfer that you're about to do. Now, the receiving agency, upon referral, you're the receiving agency, you must access the RHHI system, that as I indicated, and make sure that if there is another agency involved, like I said, that you need to address or you need to contact that other agency. Also, very important, the receiving agency must document that they've informed the patient that the original agency will no longer receive payment for services after your admission or their transfer date. So in case of dispute, let's say the other agency would dispute that you took over their case, then you protected yourself because you've sent the transfer notice, you've informed that other agency that you're taking over, and also, of course, you have to inform the patient that you're taking over and the other agency will not. Now, on the flip side to that, let's say on this screen it says overlapping episode at discharge. So that means your agency now is subject to being overlapped. So at this point, if you want your claim to be properly coded, then you need to make sure that this section of the program has to be answered correctly. There could be many factors which causes the original agency to lose a patient. We all know that, right? And thus you will receive a partial episode payment, also called PEP. But for whatever reason the episode is terminated, you have to code your discharge status with a 06. Now confirm with the CWF or DDE when the other agency took over, so that you can time the number of visits and dates in your claim. If you didn't confirm, then you could inadvertently shorten your episode and of course your money. Statistical information within the Synergy software depends on this action, this code, because we don't know whether or not you got PEP'd. And as you know, statistical information requires that we count the number of or the types of episodes that you have, whether they're full episodes, LUPAs, partial episodes, outliers, and all of these have to be provided at fiscal year end or at quarter end or at year end to your cost report preparer for statistical data. Let's talk about outliers. Well, in here, what is an outlier? An outlier is an additional Medicare reimbursement for higher utilization episodes. Outliers are not a blessing. I just want to come out clean on that one. Yes, Medicare is assuring providers reimbursement in excess of full episode rates for one or more episodes. However, to be fully paid by CMS on outlier episodes, the agency should have enough full payment episodes to support the outlier episodes. Now, CMS made it in such a way that outlier payments cannot exceed 10% of the provider's total home health payments each year. Now, an outlier payment equals roughly only about 80% of the difference between the provider's actual charges and the outlier reimbursement. So, in plain terms, outlier payments fall short of covering all expenses. I encourage you all to manage outliers and understand they are not revenue boosters. Certainly, there are specific motivations like goodwill to patients with high needs, or you have a referral source that you need to satisfy and accept some of the cases that they give you because they give you more other patients. So the point here is that you need to analyze the real cost behind each outlier episode, whether or not you're breaking even, or you made a profit, or you made a loss, because you're going to need to address the payroll amount, because you're paying the nurse twice a day or 3 times a day, depending on what is called into the outlier scheme. But that's something that has to be done before you notice that, hey, why is it that I just lost my pants on this one? Now, to help you analyze your outliers, you need to use the Synergy dashboard to monitor outlier ratios. So here's an example on the screen, and of course the dashboard doesn't only talk about or show you the outlier threshold summary, but it does show you your OASIS summaries and your plan of care and your patient status, as well as your face-to-face compliance, which is a real important issue that you need to make sure that when you're submitting your claims that you have your face-to-face compliance put into the right process. Okay, so the dashboard is quite handy in that respect, not just for outlier summaries. Now let's talk about adjusting your paid claims. This is one way that you can recoup your monies and submit those late notes that have come in after you've already submitted your claims. So I'm going to show you in the next few slides how to identify your unbilled visits and then resubmit them to your intermediary. First, let's talk about the reasons for adjusting a claim. Number one, if you discover that you have to add or delete notes not included in the original claim, then that's one reason to adjust. Let's say you had a change in an HHRG after a clinical review. Now, I don't recommend that you just randomly do or you just do this and say, okay, I'm going to have a nurse review my OASIS just so I can improve upon the score. Certainly that's not what is meant to be in here, but chances are that you would have a special consideration that you say, I need to change it. It's just completely wrong. Now you would have to cancel the claim, and then it would be as if that you're starting from scratch and you're going to submit the RAP and then the final claim. Now, another reason for adjusting a claim is if there's an HHRG pricer change. Now, there's now far and few in between on this because most of the pricer changes have been perfected at this point, given that CMS had improved their software or their calculating algorithms. Now, if you want to add non-routine medical supplies because you failed to do so, then you can certainly go back and adjust your claims. For Medicare secondary payers, if they're not related, so you got a rejected claim and you just want to take a look at and say it was not related, so I'm going to go ahead and put a remarks on the claim so I can receive my payment. Now, I want to pause for a second on this type of adjustment, and certainly putting a not related on a rejected claim because of an MSP situation should not be your normal policy. Why? Because there could be a variety of reasons why you shouldn't do it. Number one, CMS will certainly look into that, and if they discover that it is related, let's say it was selected for an audit, then they could certainly take back that money and even give you interest and penalties for doing so. Also, not related doesn't necessarily mean that it's your ticket to be able to get paid. There is a one or two MSP cases, such as working aged, that are not adjustable because of just being not related. You would literally have to first bill that primary payer, obtain a a rejection or a partial payment, and at which point you can now take a look at that particular claim and make your condition codes and then resubmit it for payment. Now, MSP is such a long topic that we do not have the time for this particular course, so I would recommend that you download that or you attend our classes on this, or you can certainly call our tech support team and ask for a one-on-one training session. Of course, we touched on the conditional billing. That's also partly reasons for adjusting a claim. That means you now received all of your rejections from the primary payer after you've done your initial billing, or you receive partial payments, so now you're going to put in the necessary codes to be able to bill Medicare on a conditional basis. And then lastly, one of the other reasons to adjust a claim is if the patient's Medicare coverage changed. So let's say there was an MSP and then all of a sudden the patient, the case has terminated, so now Medicare is now back to the primary payer, then you can just go ahead and adjust your claim and code it appropriately. And I'm going to show you the code later on at the next screen. Now let's pause for a second and understand the ledger. One of the features that we've improved upon is that you can actually now select multiple ledger items and include them to the claim in one batch or one sweep. And then in one of the little techniques that I also wanted to show is that if you double click on the last column, which is claims, it will arrange all of your ledger visits or ledger items, which pushes all the ones with no claim numbers on the very top of the list. So the technique in here is that I want you to know that if there is no claim number to the right of each ledger transaction, chances are that you've already submitted the claim and these are late items that have been entered after the fact. Okay? So I want you to understand that that is the feature in the program that would help you identify, because the program protects your data. That means once you've already marked the claim as sent, it will not add any late notes after that date. Of course, you have to be aware when you open the claim again to add new notes or new transactions, you know that you're supposed to now put in the necessary code so you can actually adjust the claim, and whether it's just to improve your statistical information to the RHHI, or if you are actually soliciting or asking for more monies based on some of those late notes that would recalculate your pricer. All right. Now, how do we identify all of these late notes instead of going through each and every one of these patients' records, right? So what you're going to do on the top left of the screen that you're looking at, you're going to go to the reports and select the subheading called Visit Reports, and go to the report title List of Unbilled Visits. So when you produce that, you're literally going through a certain range of dates. You don't want to go too much to the current period, because most of those are still probably open, or just open wraps, or open episodes that have not terminated yet. Thus, there's a whole bunch of ledger transactions that don't have claim numbers. That's of course a given, because the episode hasn't terminated yet. But for the ones that have terminated and you've billed, and you still found that they didn't have a claim number, those are the ones that will be produced from this report. So on the right hand side, the output is the actual report called List of Unbilled Visits. And in this example, we have 4 occupational therapy visits that were late. So looking at the ledger, you will notice that they do not contain a claim number to the right of that transaction record. Okay, so to be able to include these 4 visits to the sent claim, you will first need to open the claim. That way you can now click on the Include to Claim button from within the ledger and include these 4 notes. Now, my caution to you is that you want to make sure that all of the notes that you're about to include in or resubmit, these should be following the frequencies in your plan of care. They have to have an MD signature, and that they're medically justifiable. Okay, you just don't want to duplicate visits just so you can make additional revenue, obviously, and I'm sure that's something that you will not do. But certainly sometimes there could have been a typographical error or an administrative error, that somebody may have just duplicated the visit, and without you looking at it intently, you may think that those are extra visits. So please, I want to make sure that you are following or looking very closely at what you're doing when you are adjusting a paid claim. And my recommendation also is that you minimize this type of arrangement. That means before you submit a claim, you want to make sure that all the notes are in, that they follow the frequency requirements in your plan of care, and that they're all medically justifiable. Okay, moving on along. Now I'm going to show you that after you've included those notes, you're going to shift your focus into the claim section. You've already opened the claim, because otherwise you wouldn't be able to include those visits, correct? So now we're going to edit that claim in question. We're going to go ahead and tackle 3 items in the claim. Number 1, we're going to change the type of bill to a 3X7. 3X7 is basically the code that you will use to replace a prior claim. Now, you want to be uniform with the middle character or the middle digit. So if the final claim was a 339, your replacement or your adjustment type of bill should be a 337. Likewise, if you have a 329, then your type of bill for an adjustment is a 327. So if you just pull down the inverted arrow in there, you can select the right type of bill. Then the next one is the document control number. Now, for the type of bill and for the document control number information, if you are posting your payments using the electronic remittance advice method, then you wouldn't have to worry about this portion because it'll automatically put it, it would all automatically deliver your document control number in there, and then it would know exactly what that middle digit is on your type of bill. So all you need to do is change it to a 7. All right, so that's one of the reasons why I'm forcing you guys to post your payments regularly using the ERA method, because these are the byproducts of that. Now the third item that you're going to change, or that you're going to key in into the claim so you can adjust a paid claim, is the condition code. So a D1 is to add or remove visits, or to include medical supplies. Then a D2 is the condition code you use to adjust a HIPS code, or when you make changes to the OASIS, D2 is the code. And D9, of course, is the condition code that you use for multiple changes, but you have to include remarks in the remarks section from within the claim. So if you'll notice on this example, remarks is 1, 2, 3, 4, the 4th tab on the top. So for our adjustment example, that we added those 4 occupational therapists, you will notice that the old claim was 3821.44, and after we've adjusted or added the 4 therapy visits, then you now are able to, the price are recalculated, and now there's a $601.33 that you would be receiving after you've submitted and gotten paid for this particular adjustment. All right, we're going to talk about more about the managing the ledger. We touched base on that by adding, I gave you a little technique on highlighting a group of ledger transactions and including them in a sweep. Now we're going to talk about how to enter medical supplies and how to exclude a visit from a claim. So here's a picture of the ledger. Now you're going to click on New if you're going to add, let's say, a medical supplies. So when you click New, a transaction type list would appear, and all you basically would do is select the medical supplies, and then you're going to put in the amount of supplies that you use. Now many people have various different ways of adding medical supplies. It's up to you what you'd like to pursue or which one you'd like to implement. Now, some of you would enter all of the supplies that you use in the chart of accounts, but that, of course, will cause your chart of accounts to be too long, and you're going to be going up and down looking for that actual code. Some people revert to just simply reporting all of the supply usage in the nurses or the therapy notes, and then adding them up, marking them up with a value of 300%, and then putting that aggregate amount as one transaction ledger amount. The program automatically dates your medical supplies using the last visit date or the through date of your claim. So however many times that you've entered supplies, it'll just summarize it as one line transaction and include it in your UBO4. The medical supplies that you are billing to Medicare should always be backed up with an itemized list, and more importantly, they need to be approved on your plan of care or as a supplemental order by your MD. Now there are scenarios when the reason for a rejected claim is because you had an overlap with an inpatient facility, and sometimes the only there may be 1 or 2 transaction items in the ledger that got affected by the overlap with that hospital stay. So once you identify them, you can resubmit that claim again by simply highlighting, or of course you're going to have to open the claim again. It should not be marked as sent because you're going to resubmit them. So you're going to click on the status and then put it under open status. And then you're going to click on Ledger, and you're going to go through and look for the date that had the overlap. And then you're going to edit that date. You're going to simply uncheck the bill to insurance, save it, and then resubmit your claim. And so in that regard, you are still keeping the data within the claim, but it will not report it when you submit it as a claim to the intermediary or to your insurance company. Okay, moving on along. Let's talk about insurance plan changes and MSP complications. Now, we all have experienced when our claim got rejected because the patient had disenrolled out of the original Medicare and enrolled to an HMO, a PPO, or to a Medicare Advantage plan. So knowing that as quickly as possible might be a real good financial saver for you guys. So how do we develop a plan or a process that would give us the edge, or at least to salvage what we can in terms of losing more money? My recommendation is that you need to check eligibility more frequently than just at the admission level. You might want to try every month, twice a month, mid-episode. So you're going to go to HIQH or HIQA and do this. Now, some people say, well, I have way too many patients to be going through all 60 or 120 patients twice a month. So we have this eligibility assistant that certainly you can subscribe to, and you would just run it in the software, and it's part of the routine, just like your backup, and it would produce a report for you that would allow you to know exactly which patient was moved to another plan. Okay, so it's very important that you know the coverage of your patient. Otherwise, it's a no-brainer. You're going to lose money, especially if you're not an approved provider under that other plan. So when you check eligibility, or when you check HIQH, it's only coded, the insurance company is all in some kind of a code. So you would need to download the CMS plan directory, so you will identify who the plan is, the name and their contact number. So to be able to get all of your money due to you, you can still call that plan and find out if there may be a coverage that they will pay you. So it doesn't hurt to submit a claim. All right? But you need to identify the start date and know when to end Medicare's claim and when to start theirs. So certainly there might be some modifications that you would need to do on your claim. You may have to create a brand new admission for your new Medicare, for your non-Medicare insurer. That way you can separate the dates completely away from your Medicare episode. All right, a tool that we have available for you is called the Eligibility Assistant. This is within the program. It automatically monitors existing active Medicare patients' coverage changes. So it tells it to you in red. You can run it however often you'd like. It's a very nominal charge that you can purchase from us, but it does give you patient insurance details and reports it in the insurance section of the patient's record. So, but the Eligibility Assistant is a viable source or a viable solution for you that will give you a chance to know exactly if your patients went over to a different plan. If you need more information about Eligibility Assistant, I'd like you to call 1-800-479-6374, which is the Synergy number, and punch in extension 117. You'll be connected to a staff by the name of Lena. Now let's talk about Medicare secondary payer now. Well, I'm not going to show you all of the ways to submit a Medicare secondary payer. I just want you to give the insight of some of the reasons why you end up getting your rejected claim. And of course, this Medicare secondary payment billing course is probably a course but in itself, so I would recommend that you attend some of our series of webinars on Medicare secondary payer. But foremost, once again, I can't stress this, is to check eligibility. And you may have to alternately use HIQH and HIQA. HIQA identifies who is that payer in there, so that way you can make contact with that payer and identify the patient's coverage information. All right. But you need to include a questionnaire at the time of admission. That way, the clinicians already out in the field would determine who is actually going to be primary over Medicare if applicable. There are many different insurance companies out there now that are actually pooling their information along with Medicare through what they call the coordination of benefits system. So by you at that point of admission, you will reduce your chances of losing a lot of money if at that moment in time you've already identified all that information. Now, many times you still have a way to actually get your payment. So again, I encourage you to attend the MSP course on how to create a claim. But you would build the wrap to establish an episode in the common working file. If applicable, you would need to submit to the primary payer your claim. Now, if you've already submitted your wrap and then here you are, you're submitting your final claim, if you know that it's not related, then you can already mark not related on the remark section from within your claim. Now, as a caveat, I want to warn you that you cannot do this for working aged. Working aged simply says that there is probably a spouse or the patient in itself has still a group health plan that is primary over Medicare. And Medicare will not allow you to just simply say not related. And also the other item that I'd like to tell you, you cannot mark your MSP claim as not related if it's a liability or an accident, but you are using a diagnosis code as a primary that starts with an 8. The 800 series of diagnosis codes are usually designated as trauma. So at that moment, Medicare will say, well, maybe it's still related. So I'm not going to accept your remarks that it's not related, because obviously there is some kind of a reason that could potentially have Medicare push you to that primary payer because of the diagnosis codes of your choice. So these are just tips, and sometimes they work, but again, all of these claims that you're submitting to Medicare may go through an actual submission. Yes, sometimes the system would just automatically pay it, but certainly there could be a review process post-payment that could potentially backfire on you if you didn't do the right thing on these Medicare secondary claims. Okay, so no MSP billing. Learn the conditional codes that are needed, so that way your MSP claims will get paid correctly. And if you need help on some of these nuances of putting it in correctly into the system, our tech support team are always available and willing to help you. So just give us a call. And on the bottom of the screen, I showed you the regulations and manuals that you can print out and use as a guide, so that way you already know your codes, your conditional billing codes. Now, our tech support team, yes, we will help you, but unfortunately we cannot give you the right code that you need to put into your claim, because only you know the profile and the parameters of billing this MSP claim. So be prepared to already know what these are, and then we'll certainly show you how to plug them into the Synergy claim. All right, so we have exceeded our 1 hour, but we're almost to the end of our course. And what I wanted to introduce to you today is other revenue sources. So we are able to do billing for Medicare Part B as an extension of your Part A license as a home health agency. One of them is outpatient therapy care. Now, when the patient is no longer homebound and certainly could still benefit from all of the good things that home health does for patients to get better and to be independent in the community, then certainly extending more outpatient therapy care would be good. And you will actually bill using your Part B component, but you can still submit the claim through your regular submitter access through your Medicare Part A account. So what is outpatient therapy care? Outpatient comprises of your PT, OT, and ST, which are hopefully going to help complete the rehabilitation goals of your patient. So like I said, it's extended to non-homebound patients, and you can bill it through your Part A and B license. Now, we do have also a course on outpatient rehab module that you can take advantage of. But my point here is that you can make more money, but there is, of course, a cap for each patient up to, I think, about $1,700 or $1,800 per year that you can pick up off of this. So, unfortunately, we want you to understand the right ways of taking care of a Part B, an extension of your outpatient therapy care, because there's a lot of intricacies involved. And so again, we will help you plug in the modifiers, all of these items that you need to get a paid claim, but you still need to know the back end or how your outpatient claims are compliant and if they meet all of the regulations of your RHHI. So that's the caveat that I'd like to present on outpatient. Certainly you can make money, but you still need to know what you're doing in basic terms. Immunization, okay? Typically the start of the flu shot initiative is September. So we're in December, so I'm pretty sure there's still some runoffs, but if you missed it, then we can certainly start it next year. But Medicare pays the administration and the vaccine at rates similar to physician practices. So this service is available to original Medicare Part A and B recipients, some HMOs, but really it's geared only for Medicare Part A original recipients. The insurance plans may or may not be covered. So my recommendation is if you have some Medicare Advantage like Humana or Blue Cross, then you may have to call them directly to find out if you will be reimbursed for them. But this particular practice of immunizing your patients or going into a fair or opening it up for your community is an excellent marketing strategy. You can hold flu clinics, creating goodwill and visibility in your for your home health. All right, but make sure when you do this flu clinics, you ask them to give you a copy, or you may have to take copies of their Medicare card, because that way you know for sure which you don't have any transpositions or incorrect submissions. Okay, but the Synergy program is also able to bill for you. I'm sorry, you can bill through the Synergy software for these immunization shots. We have a course, again, that's available. And all we need to do is just study through it and learn it. But it's an excellent strategy for bringing in more money into the company, as well as the goodwill. I know you'll probably say, Cecile, it's just like probably $50 that I can get. I mean, it's still $50 coming into your pockets. All right, so we're nearing to the end of our course. I would like to mention the partnership that we have with the Ability software. We are introducing their new service called Ease and Complete. For billers that are not comfortable in navigating into DDE, this is an additional paid service from Ability, but it can be both a big help and a time saver. Ability allows the user to access the list of patients' eligibility and is intuitive enough to correct claims through a click-to-fix option. All right, but you need to subscribe to DDE. It's not like when you subscribe to Ease, you're going to forsake DDE. No, you still have to subscribe to DDE. unfortunately, but it's up to you. If you feel like it's something that you'd like to utilize, then I just want to warn you that there's additional payments involved. Um, but that's Ivans and eSolutions do probably have something similar. I think eSolutions has it more so than Ivans. Now, the ability to catch patients switching to an HMO within a few days as compared to weeks and months could mean a bigger loss to the agency. So it would also be able to track your MSP situations using that tool from Ability. Now, talking about submission of claims to private insurance companies, you might want to investigate into submitting it through a clearinghouse rather than having to submit them on paper. We all know in obvious reasons that when you print and mail out a piece of paper, it takes a long time for you to get paid. So third-party tools, electronic claim submissions through your through a clearinghouse. In most cases, you can detect the errors upon submission, and you can quickly remedy the claim rather than having to see 30 days later that you submitted a paper claim and it's wrong. Of course, like I mentioned to you earlier, they're also able to download ERAs and 277 files. So all in all, with your private insurance, don't discount them because they're still a viable source of revenue for you. Just put in place ways that you can actually make submitting the claims to private insurers a lot more efficient and a lot more easier to do rather than submitting it through paper. Okay? Okay, now let's open it up through some questions